and the Director of Cancer Health Equity for the Huntsman Cancer Institute. Wow. Her life's work exhibits a passion for ameliorating health inequities and addressing human suffering. Her work ranges broadly from clinical research all the way with molecular targets all the way to healthcare services research. All her efforts consistently contribute to optimizing the health of individuals and their communities. As you'll see by reading her bio, she's a very accomplished individual, and we are lucky to now have her in Utah. She's a recent transplant to the state, and so she knows not just about Utah, but about other states as well. So with that, please welcome Dr. Ana Maria Lopez.
Thank you so much for the kind introduction, and thanks to all of you for your attention. I'm not sure this will. Can you hear me okay? It sort of reaches my nose, so I hope I don't sneeze. So it's really a great pleasure to be here with you today and to meet you. As Matt mentioned, I'm new to Utah. I moved here in February. And really just getting to know the community, getting to know your needs. And it's been a great pleasure to do that and to share with you some of the data that I've been able to glean, and look forward to your thoughts and questions after the presentation. So as we look at this problem of health disparities, I think it's very, very important that we be data-driven. So everything that I will share with you today is referenced, and a large portion is from your recent 2015 report on the Utah health status by race and ethnicity. So we need to look at the data, and we need to look at the data always with skepticism, because the answers that we get are very much linked to the questions that we ask. So we need to think, what are the limitations of our data? How can we ask better questions to improve outcomes, which is our ultimate goal, improving healthcare outcomes for all. So let's take a quick second and just look at health disparities. Now, Healthy People 2020 looks at defines health disparity as a type of difference. And you know, there are lots of potential differences, right? There can be economic, there can be social, there can be environmental, and there are lots of different groups that experience this, that can experience this. So, and some of these are linked to historical discrimination or exclusion. So that's really the context for disparity. And if we look at the concept of equity, what is health equity? And this is a more recent concept. But what I like about this concept is that it really expresses and is linked to an underlying commitment to reduce and really eliminate disparities. Now, I'm a clinician, I'm a medical oncologist, I'm all about healthcare. It is absolutely incongruous to care, to say some people will do better and some people will do worse for some of these factors, right? There can be, some people may do better, some people may do worse because they've got worse disease. But these other issues, these social determinants, and I think of them as social determinants of illness, we really need to be committed to identifying, addressing, and eradicating. So I really prefer the term health equity, which is more of the public health definition. What about race ethnicity? What does that really mean? And what are the limitations? Now, you know, race, that's pretty much a social construct, right? Anybody in this room that is 100% sure that you are 100% whatever race you think you are? Yeah, right? And isn't that a wonderful surprise when any of us do these tests or swabs like from National Geographic that get our DNA checked, and we see the wonderful variety in our DNA and where our history has come from? So race is really not an effective concept. And more scientifically, people are saying, you know, this doesn't make sense. Ethnicity, you know, can be linked with culture, and there are cultural commonalities, but you know, I'm Latina. And you might look at me and say Latina and make assumptions about me. that may or may not be true, because I'm actually Latina from Bolivia. And that may not be immediately apparent. So, in the wide diversity, again, there's a lot of variability. So some of the thinking now is to really look at genetic admixtures, to really look at the different patterns, because I may share some very common genetic admixtures with somebody who looks very different from me, and that may be much more predictive about my health or about their health than other factors. So really important for us to think, yeah, this has been the usual way to analyze these data, but is this the most effective way to ask these questions? What are some other important questions for us to think about? What is health? What is disease? What is illness, and why does this matter? Why is this important? And what are the factors that are promoting health, illness, outcomes? And you can't cheat and say health is absence of illness and illness is the opposite of health. But to really think about that substantively for you, for your family, for your community, what does that mean? And we've actually started this wonderful series at the University of Utah Health Sciences where we're bringing in folks from different groups and saying, from your perspective, from your patient voice, what does healthcare quality mean to you? So we can learn from our communities and gain a better understanding of these just really essential elements. And why is this important? Why should we care about health equity? Certainly there's the personal cost to the individual, there's the cost to the family, there's economic cost to society, loss of productivity. And are there other costs? Are there risks down the line? If, for example, and many of my examples will be oncology related simply because that's what I do, but I guess I'll put that out there as a bias initially. But there was a time when cancer was completely incurable, and one of the earliest cancers that became curable was Hodgkin's. And that was wonderful because you saw young people that were surviving. But you know what? The women with Hodgkin's were at higher risk for breast cancer, were at higher risk for thyroid cancer, and that was due to the treatment. So important for us to think about what are even the costs of the therapy from that perspective. And what do we know about Utah? What do we know in the context that can make a difference regarding health and well-being? So we'll look at the data. If at any time you have a question or a comment, just let me know. I think that there's no time like the present to address something. So the population is growing, nearly 3 million. You see the percent change, percent growth higher than the rest of the country. You see a little bit less women than in the rest of the country, but really not a significant difference at all. And what do you notice about the age? That overall tends to be a younger population. Now, some of that was generally attributed to births. Now some of that is attributed to folks that are coming to settle here, that they tend to be younger. So Utah population growing faster than the rest of the country, and younger. And generally when we think of younger populations, we think of healthier populations. But let's explore that a little bit more. Always take another step. Let's look at that age equation again. And we see the median age of all Utahns to be 29.6. But what do you notice about the differences among the subsets of populations? And again, we need to understand that these are self-identified. Some people may be multiple ethnicities, multiple races, but at least the way this was classified and the way this is presented, we see that the youngest group, African Americans, median age, 23.4. Latinos, 23.6. Native Hawaiians, Pacific Islanders, 24. American Indians, Alaska Natives, 27, and white, non-Hispanic, 30, and Asian, 32 and a half. So a young population overall, but the population that is younger are these growing non-majority populations. And indeed, I think all of you are familiar with the change in demographics. And this is, I think, a very interesting statistic that I've heard often, that half of the children in the preschools in Salt Lake are non-white. So changing demographics. What more do we know about the changing demographics? And from the census data, we see that although the numbers are changing, relative to the rest of the country, they're still less. So perhaps you've heard Pam Perlich and her lovely talk on demographics, and where she says the numbers are changing, they're just a generation or so behind the rest of the nation. But emerging and important for us to think about, this is our population, how best to care for our population. Where do folks live? And I don't know if you're familiar with these sorts of maps that look at race, ethnicity, and look at cities. I couldn't find one for Utah, but I did find one for Salt Lake. And again, based on census data, blue is where white populations live. Green is African American populations. Red, Asian populations. This sort of goldish color, Latino populations. And you see West Valley, and you see sort of the northern, maybe western part of Salt Lake. And you see one little spot of red, but you see a lot of blue, and then some segmentation. It's important for us to think about when we think about healthcare, because we need to think, where do people live? And are people exposed to different healthcare risks based on where they live? So these are great and wonderful maps to study. So I think all are on the same page. The demographics are changing, that what had been a relatively homogeneous population is becoming a more diverse population due to births, due to people moving, and that the change is more prominent in the more populous states. What are some of the other, in the populous areas, I'm sorry. What are some of the other factors that we can look at that may be significant? We can look at socioeconomic status, and here in these data from the 2015 report, we see what percent of the different segments of the population were living in poverty in 2013. And you can see the bar graphs and the differences. Overall, 12.6%. And you see the variability. I also want to point out to you these bars, because that shows the variability in the data. So if there's a lot of variability in the data, there may be questions in the reliability of the data, or at least we need to be aware that there's a lot of difference in how this is being presented, right? So we have the percent, but there's a wide range in there. So interesting, because then if you look at the range at that line, there are definitely segments that may be experiencing a lot more poverty. What about population density? And here's another map that I think is important for all of us interested in public health. There's a lot of green on that map. So we're not only a square state, where there's beautiful scenery and wonderful countryside, but we're a square state that's very sparse. The green is less than one person, the deepest green, less than one person per square mile. less than one person per square mile. I did my undergraduate, my medical school in Philadelphia. It's like, you can't even fathom less than one person per square mile. And you see the red, and where do you think that red is? Salt Lake, right? So population density, and this can have serious implications for healthcare. Because how do you get to healthcare if you're living in a space where there's such sparse population? There can be significant limitations. And if we look, in another way of looking at the data, you see the land area in square miles, and you see the average persons per square miles in 2010. In Utah, 33.6, in the rest of the nation, 87.4. So it's a significant fact. And what is the way that most people get health care insurance? And you were speaking about that earlier. I'm sorry, the way most people get health care is they access health care through insurance. So certainly we see differences in access and availability of health insurance and the folks who don't have access to health insurance. And very important, again, not just to look at the facts, but to think of why. You know, are folks just not used to health insurance? Do they not understand the concept of health insurance? Feel relatively healthy, therefore they don't get health insurance? Is it a cost barrier? So there are data, but the data only explain what is, not the why. And why is this important? I mean, I know that this is a passion for many of you, but again, from my perspective as an oncologist, as a clinician, the cost of healthcare is really a form of financial toxicity. So I talk to my patients about, you may get nauseated, you may lose your hair, you may get a fever, you may have mouth sores, and this treatment may result in bankruptcy. The most common cause of bankruptcy in the United States is now due to healthcare. Shocking. So we need to think about not only are patients aware, are we transparent as healthcare systems about costs? Do we even know how to do that? I mean, these are serious questions that we're all grappling with. And there are folks that may have insurance, but can we educate folks so that they understand the difference between healthcare insurance and underinsurance? You know, I think many of us, when we look at the options, we'll just pick, okay, this is the least costly one, and not necessarily thinking of the benefits. I do want to say a word about healthcare accounts, because I think that that's an emerging interest in many communities and in many populations. And the worry, I think, that many of us have, and actually now there are data, because the concept was that health account would result in smart shoppers. The problem is it's really hard to know the cost. University of Utah is working really hard to figure that out, but it is really hard. And without that, it's hard for patients. And what patients then do is don't follow up with care. And not following up with care can have dire consequences. So maybe a good option, but maybe not quite right for prime time yet because of the lack of transparency. Other factors, health workforce shortages. And in Utah, we're actually 49th. So there are 1,861 primary care physicians, and according to the AAMC, that's 65.2 per 100,000, so we rank 49th among the states. So this is really important because we need primary care physicians. We need generalist docs that can take care of all of us, and especially of the growing elderly population. Lack of physicians, lack of healthcare professionals, and lack of healthcare professionals from this emerging diverse community in Utah. So our population, rural frontier, overall younger, increasingly diverse, relatively segregated from what data we could find, variable access to health insurance, and 49th in numbers of primary care physicians. Are we all on the same page? How's Utah's health? So we'll look at some of these data. And really significant, one of the areas that is just a standard way is to look at maternal health and to look at infant mortality. We'll also take a look at the main causes of mortality: diabetes, vascular disease, and cancer. So what does Utah look like when we talk about maternal health? And when we talk about maternal health, this is often linked to early prenatal care, and then we also look at infant mortality. So if we look at the data that was presented in the 2015 report by ethnicity, by race, you see all Utahns, about 74%, receive first trimester prenatal care, but you do see variability with a low of 42% of Native Hawaiian Pacific Islanders. But when you look at the infant mortality data, you see that the white population, white non-Latino population, and the Latino population are actually fairly close, despite some differences in access to care. And the American Indian Alaska Native outcomes for infant mortality are also relatively close. So that just sparks some questions, right? That there may be other factors that may be protective in some of these cultures, despite the differences in access, in maybe not access, but use of prenatal care. So important for us to always be thinking what other questions there might be. Another graphic, this is from Utah Vital Statistics, looking at infant mortality. And what I like about this is it just looks at it over a span of time. So you can see if populations are getting better or not. And you see variability, you see some stability, and again, important for us to think, is there a reason for that? So for example, we just looked at the Alaska Native numbers had decreased, fairly similar to Latino and white non-Latino populations. Again, we don't quite know why, but interesting that there had been a peak and then a drop. What about diabetes? Diabetes prevalence. Now this is so significant, although the CDC just came out and said that the incidence of diabetes is decreasing. So that's a great observation. But up until recently, had a steady rise and was actually threatening to shorten life expectancy. And in some populations has shortened life expectancy. And you see some variability, and you see some populations at greater risk. And we have to think of what are the associated factors that may contribute to diabetes. And I think we're all aware of these: obesity, lack of physical activity, and nutritional factors. And physical activity is really emerging as being as significant as smoking for health promotion, as a health risk. So really all of us should be standing, should be walking. I think we should have meetings where we walk and talk. When I was in Arizona, we had this wonderful program, which we can start here with all of your help, which was Walk with a Doc. And it was every weekend in different parts of the city. And docs, so there were different docs from different areas walking with their communities. And you might pick a topic, so if somebody who maybe is a cardiologist would want to talk about heart disease risk, or if somebody who was a bone doctor might talk about, risk of injuries, or somebody else might talk about osteoporosis. I mean, the topics were endless, right? Not intended to be, I'm giving you a consultation, but we're walking and we're talking, and that as clinicians, we're practicing what we preach. So physical activity is very, very important. Now, we'll say more about all of these factors. What I want you to notice is that in every one of the areas that I said we would outline, obesity, physical activity, and nutrition. Shut up. So this is a tremendous opportunity for healthcare, for disease prevention, for health promotion, is to address obesity, physical activity, and nutrition. So let's look at some of the aspects that promote heart disease and stroke. And if we look at cholesterol check, and again from the 2015 report, we see that the white non-Latino population, 70% or so have had their cholesterol checked, and then you see pretty good actually in most of the populations, 69.6 as the low and 71.2 as the high, so fairly similar across all. And then you see where the diagnoses have come, and you see that the Native Hawaiian Pacific Islanders, 26.2, the white non-Latino population, 25%, the other populations at lower levels. So high cholesterol, a risk factor for heart disease, many populations getting tested, and appears that a couple of populations maybe have identified the high cholesterol more so than others. Hypertension. Now the problem with hypertension, you know, is you don't feel it. You feel fine. So getting checked for blood pressure is very, very important. And again, you see the diagnosis, some variability, higher in African American populations than Native Hawaiian Pacific Islanders, and lowest in Asian population, next lowest in Latino populations. So differences, some may be significant, some may be more similar, and whenever we see a difference, for example, 35.4 versus 22.8, we might ask why. Well, what's different in the populations, and maybe we'll glean some of that as we speak more. Cancer. For cancer, there are lots of different points of disease, right? You could try to catch the disease early with screening. You could try to prevent it altogether. Is it almost 5 minutes? Oh my, I'll speak faster. Okay, screening, primary prevention, stop smoking, and then obesity, physical activity, and nutrition again. Cancer screening, these are the screenable cancers. This is what you want to ask your doctor for. Screening prevents disease. Very important. If you look at colon cancer screening, you again see differences in getting the screening test. Whites, non-Latinos more so than Native Hawaiian Pacific Islanders. Some variability. Mammogram uptake, fairly similar, and actually African Americans and Asians with the highest report of having had a mammogram in the past 2 years. Pap smears, cervical cancer should really not exist, ever. If ever a woman has cervical cancer, that is a failure of screening, and that is our fault. This should not happen. And you see that the numbers are pretty good. Latina 78.8, so nearly 80%, but American Indian, Alaskan Natives about 55.6. Primary prevention, tobacco. Anyone you smoke, ask them to quit. And you see some differences that even today, with all the knowledge, and this is so important because there's so much knowledge, but yet we don't act on that knowledge. And all of us interested in public health try to understand this. E-cigarettes, emerging. We don't quite know what this means. Definitely some variability, higher uptakes in American Indian, Alaska Natives, and Latino populations. And HPV vaccine. We have a vaccine that can prevent cancer. And yet the uptake is low. And you see the numbers in Utah, you see the US numbers in both males and females. I want to say a word about dental health simply because it's often ignored. And dental health is very significant because if your teeth aren't working, it can impact your nutrition, and it also increases inflammation. And we know that inflammation is probably a root cause of multiple chronic illnesses. So folks that have had a routine dental checkup, and you see variability, and you see the lower numbers in African American population, Latino populations. How do lifestyle factors fit in? Overweight, obesity. You see that there's the lowest in Asian populations. And we'll re-examine this when we look at nutrition, if we can get there. No physical activity. You see some differences, but you really see that there are many commonalities. We also have to think that the population that's attracted to Utah tends to be a population that wants to be physically active. So how can that be promoted? The attaining the amount of recommended aerobic activity, and you see the differences by ethnicity, and this is actually adjusted by age. For nutrition, vegetable consumption, and where is it highest? In Asian populations. And they were leaner, yes? Maybe there's an association, something to think about. Daily fruit consumption, now really the most important thing is vegetable consumption. Fruit, you want to have the question was 2+ fruits daily. And what's a significant reason why people do not have the recommended nutrition? Because there are food deserts. I couldn't find a map of a food desert specific to Utah, but this map looks at, you can see the country and you can see Utah. And you can see that the dark green, those are the areas where there's less access to fresh foods. So we do have a Utah conundrum, less expenditure on health, but overall pretty good health outcomes. And probably because there's a healthy population overall, a leaner population overall, a population that is somewhat more committed to health, and less obese, less tobacco, less alcohol, more physically active. But in one area, there is concern that is unique to Utah, and that's mental health. Consistently, self-reports of mental health in Utah are higher than the rest of the country. And the question is, in the past 30 days, have you had 7 or more days where you felt your mental health was not good? And you see the variability among the different populations, with American Indians, Alaska Natives, approximately 20% in this time period saying yes. Depression ever diagnosed? You see the numbers. Nationally, the rates are about 20%, and you see the rates in white non-Latino populations, about 22.4%. Alaska Natives, American Indians, 21%. And the lowest in Asians, 8%. Significantly different from the rest. So important for us to ask and wonder why. Life expectancy by gender, increasing over time, as would be expected. Utah life expectancy by ethnicity. Latinos at 82.4. All Utahns at 80, and white populations at 80.3. So I hope you find these data very, very provocative, because we need to think of what are potential factors that are resulting in these differences. And any of these are worthy of study. So we need to think of multiple factors, think of where people live, urban, rural, frontier, socioeconomic status, food deserts, and as we think and learn more about this, we need to think about educating ourselves, educating others, but education is not enough. We need to think of what enables a person to use what he or she has learned. And that includes access to culturally and linguistically competent care, methods to address social determinants of health, and bridging literacy, numeracy, and providing psychosocial support. So thank you very much for your attention. I really look forward to it.